Wonderful. Welcome, everyone. We'll wait until 12:15 to get started as everybody signs in, but it's great to see you all here. All right, welcome everyone. It's 12:15, and so I think we'll go ahead and get started. We are so happy to have all of you attending. We are really excited to present this first session in our series on substance use and pregnancy. Our first session today will focus on the medical model of substance use disorder. And I'm Andrea Knittel. I'm a general OBGYN at UNC. And I also provide pregnancy care at NCCIW in the state prison system. And I'm really honored to be presenting today with Dion Evans, who is a nurse at UNC Horizons and also works in several jails as a nurse there, with Essence Hairston, who is, by my definition, the answer to all the things, who runs many of the all the outpatient services for UNC Horizons in Wake, and also really leads all of our connections with folks in jail and prison. And then with Elizabeth Johnson, who is a nurse practitioner and the primary clinical provider at UNC Horizons. So a really fantastic panel of folks today. And I'm excited to learn from them with you. And so I just will put up here our accreditation, credit, and disclosure statements, which are that the University of North Carolina at Chapel Hill School of Medicine is accredited to provide continuing medical education credits, which can be claimed as continuing education for nursing and other healthcare staff. And we are also happy to generate credit statements for other professionals as well. It is eligible, so this session, which is 30 minutes, is eligible for half of a credit if you attend all 4 of the lunch sessions, which will be each of the next coming Wednesdays. You can claim up to 2 hours of credit. And then in terms of disclosure, I, who am the course director, and all of our presenters have no financial relationships that are important to disclose here. And so I've given you a little bit of an outline, or rather a little bit of an introduction of who we are, but we are all part of UNC Chapel Hill. And within that, we are connected with UNC Horizons, which is our perinatal substance use disorder treatment program. Many of the folks on this call provide care and services to folks in our residential treatment program, but we also have outpatient services as well as a housing model. And through Essence, the reach of Horizons is truly across the state into jails and other facilities everywhere. And so through the Justice Core Project, which is the specific subset that is bringing you this training today, and we'll talk more about specifically the services we can offer, UNC Horizons and UNC broadly is available to provide resources related to substance use in your jails. Today, we're going to talk about the medical model of addiction. We're going to talk about what it means for jails, the implications of that model for how we talk with and about our patients or clients, and then how to refer or request technical assistance from us in this arena. And so I will hand it over to Elizabeth Johnson to get us started.
Thank you, Dr. Canettle. Hello, everyone. Hope you all are doing well. I really appreciate you guys taking the time to spend your lunch with us today. I'm just going to get us started. So when we think about the medical model of addiction treatment, it really is an approach to thinking about addiction and substance use disorder as a chronic disease, much in the same way that we think about diabetes or hypertension or other such things as chronic diseases. And so in the same way as we approach some of those other diseases I mentioned, we have the same kinds of things that we do. So we screen, we do some testing, we think about other kinds of issues that could be going on for that person, and then we come up with a plan of treatment. So for example, if you have a patient, so I do OBGYN care, I'm here at Horizons. So let's say I have a patient who comes in, who's sneezing. One of the things, particularly now, of course, in the time of COVID, one thing we might be thinking about is, oh my goodness, does this person have any symptoms that might be consistent with COVID, or might they have some other kind of infection happening? So I want to do some testing to try to figure that out. And then, of course, I'm going to give some recommendations for how this person might be able to feel better. So think about it in the same way. If this person came in and was having some sneezing, and I did some screening and talking to my patient, and wow, we talked about their cold, but then maybe also it became obvious to me that they were not feeling well. And it didn't seem to be consistent with a cold, but maybe actually their runny nose and their aches and all of that is because they're withdrawing from opioids, for example. So I would do the same thing as far as taking care of them and coming up with maybe medications to help treat their opioid use disorder and getting them referred to services that are going to help them feel better. So I'm not sure how familiar you all are with sort of the diagnostic criteria. So for those of us who work in the substance use and mental health field, the Diagnostic and Statistic Manual, we are now on its 5th iteration, so the DSM-5, has really specific criteria in order for someone to be diagnosed with an opiate use disorder. And they're all listed here. I'm not going to read them all out to you. And another thing that we do when we are doing a screening and an assessment on someone is we are able to try to figure out, is this a mild opioid use disorder? Is it moderate or is it severe? So you can kind of see the difference there is that mild, that maybe they only meet 2 or 3 criteria. moderate is 4 to 5, and then severe is over 6. And these are things we're really looking at a wide range of ways that their substance use might be impacting their life. It is really important to note that if the only thing happening for this person is what we call tolerance or withdrawal, so let's say someone has been prescribed pain medication for a knee that they've had a problem with. If they're taking it longer than, a few days to a week or so, and you stop taking it, you are going to have some withdrawal. That alone does not mean you meet criteria for opioid use disorder. So we need to be looking at some of these other aspects as well. And when we start to think about the medical model of substance use disorder, it's one of the primary things that we're thinking about when it comes to addiction is the chemical dopamine. And probably many of you have heard of dopamine. It really is sort of the feel-good messenger that's in the brain. And it's one of the very sort of basic needs that we have. And there are some really interesting, there's a really great video on YouTube if you're interested. I can drop it in the chat later. But this sort of talks about dopamine and its impact on the brain as well. But I think one thing to be aware of is that if you think about the best day you've ever had in your entire life, everything has gone well, the sun is bright in the sky, birds are singing, maybe you see a unicorn, I don't know, but it's just been an amazing day. For those of us walking around, that's about 100 nanograms of dopamine. That's an amazing, amazing day. When someone uses a substance, particularly for the first time, that is 500 to 700 nanograms of dopamine. So 5 to 7 times more dopamine flooding the brain. So it really, it's a very different experience, and you begin to understand what's going on in people's brains. And over time, people who are using substances are using just to try to meet their baseline. Because over time, the amount of dopamine that's in your brain, actually, your brain starts to adjust. And what you sort of naturally make on your own is not that high. And so you're constantly just trying to feel normal. So you're not actually being impaired or anything like that when you continue to use. You're just trying to feel normal and be able to operate. So how do we manage addiction? So again, we really want to follow the chronic disease model. So it's real important that we assess. So it's screening. And when we talk about screening here, and particularly, the majority of us here work specifically with pregnant and parenting people who use substances, but it's doing a verbal screening so that the terminology can get sort of confused sometimes. Some people say screening and they mean urine toxicology. But when we talk about screening, we're talking about a verbal screening. So asking people about their substance use. And you also really want to be able to rule out the other causes and symptoms. So if someone comes in with a runny nose, again, they could have a cold or they could be going through withdrawal. You really need to be able to understand the difference. We want to be able to diagnose. So as I talked about, using the criteria that were laid out by the DSM-5. And it's also really important that we're thinking about other physical and mental health conditions. So a lot of times, and I'm sure you guys have seen this in the jail system, is that people may have some significant physical and mental health conditions that go along with their substance use disorder. Because when people are using substances, sometimes they are not taking care of other aspects of their health. And so things can be going on. And then, of course, we want to do some treatment. And so medication plays a very important role for opioid use disorders. So medications such as buprenorphine, which comes as Subutex or Suboxone, the brand names. Also, methadone has been around for a long time and used, and then naltrexone. So those medications are really vital to stabilizing somebody so that they can then dig in and be able to participate in behavioral health services, which are an equally important part of treatment for people with addiction. So when we think specifically again about pregnancy, it's real important to understand that dopamine is dopamine is dopamine, and its importance in our brain and what it does for us is the same, pregnant or not pregnant. So it's real important to understand that for people who are pregnant and going through withdrawal, particularly from opioids, there are risks to the birthing person, but there are also risks potentially to the unborn baby. And so you've got two patients. That's what I think about all the time in the OB clinic, is I'm actually taking care of two people. The birthing person who's here with us, and then the unborn baby as well. So the opioid withdrawal really can create a risk for both. And so we need to treat it in the same way that we need to treat hypertension and diabetes during pregnancy. We really need to be paying attention and using medications and behavioral health interventions to take care of pregnant and parenting people. And I'm going to skip back and let Dion get closer to the microphone.
Hello, I'm Dion. I'm one of the nurses that work with UNC Horizons as well. Medical model in jails. Addiction is not a moral disease. Nobody grows up and chooses to be a drug addict. You know, things happen, and I try to tell people it's not my job to judge people. It's my job to treat people. Separate the crime from the medical problems, and whatever they done did, it's still my job to treat them and give them the best treatment. Assessment, diagnosis, and treatment of OUD as a chronic disease. Like she said about hypertension, we all know how serious high blood pressure is, and everybody knows what high blood pressure is. And we can say that person needs to take their medicine because they got high blood pressure, but we never say, maybe they put too much salt on their food, or maybe they ate too much fried food. Maybe that's why they got hypertension. But when it comes to substance abuse, it's always that, maybe she should be ashamed of herself, using drugs in pregnancy. But she didn't choose that route. It's just things that happen. And, with the drug use today, it's getting more and more out there. So, we need to identify needed resources and referral, find out what we can do to help refer them. We like to say UNC Horizons is a good place to refer people, some kind of help. Managing OUD in a jail, assess, screening for substance use. Like you said, we screen with questions and a urine drug screen. So we definitely hit it on the head. Rule out any other causes of it, determine the severity of it. Because you have clients that come in and you can look at them and tell they are sick. Their nose is running, they can't sit still, they shaking, they jumping, they moving, they fidgety, they don't want to talk to you, they don't want nothing to do with you, and it's okay. My job is to still treat them, and a day or two, I know they'll be okay to come and say, hey, I feel so much better, Treatment, medication for opiate use disorder, behavioral health services. Back in the day, it was no such thing as bringing methadone or buprenorphine into the jails. It was unheard of, and people just suffered with over-the-counter medications. That was all we gave them. And then we have, so many places people bring medicine. If you're on that program, they will bring it to you if you're incarcerated. So our job is to make sure they get the medication, and, even a pregnant woman, if she's not on it, we're going to have to treat her. We're going to have to, treat her with some kind of medicine so she'll have a safe pregnancy. Okay, that's my point.
Awesome. Thank you. So I am Essence. I'm also Horizons and Justice Core as well. So one of the things that I really like about the medical model is this idea of compassion and empathy. And so you may be sitting here like, oh, my medical, dopamine, physical health. Wait a minute, this is all provider language. And so one of the things that I really like to talk about is the importance of language and how language can either encourage individuals to access treatment or to disclose their use, or actually deter them from wanting to get treatment. So it's really always, always important to use person first language. So looking at it from this humanistic approach, recognizing that individuals are more than their diagnosis. So wanting to use words that show a person has a problem rather than that person is a problem. So again, separating what's happening in that brain, right? That low dopamine or that trauma, what we're seeing, and separating that from the actual person, the human that's in front of us, as well as avoiding terms and negative connotations, associations that actually perpetuate stigma and bias, as well as punitive attitudes, as well as blame. So what I really like about this graph here is some examples of how we can actually use some trauma-informed or some compassion-informed language. Oftentimes you'll hear someone may say, a pregnant opiate addict, right? So again, thinking about when we hear that, what comes to mind, right? What are we seeing? What are we visualizing? So instead, we want to use language such as a pregnant woman or a pregnant person living with an opioid use disorder or been impacted by opioid use disorders, similar to addict and or user. So for individuals who are in recovery, we want to honor how they want to self-identify. But when we are taking care of individuals in terms of like behavioral health or medical providers and or let's say even in the jail, again, using language that supports that human, that individual, recognizing that person who we're working with. Oftentimes we'll hear addicted baby, so or addicted crack baby, which we know has impacted the Black and Brown community for decades and continues to impact communities in how people show up and treat for this population. But like Elizabeth said, we got to have we got to have some, we got to have checklists, right? So off that 11 DSM-5 criteria. So if you have 2, you have 4 or 5 or 6 or more. So we know that babies, it's impossible, right? For babies to actually have a substance use disorder because it's impossible for us to actually check off any of those criteria. So again, just recognizing the importance of language, even it's not on here, but even thinking about individuals who is incarcerated, you can even use the same approach of individuals impacted by substance use while experiencing incarceration. So individuals that's impacted by incarceration. So again, just recognizing the importance of using person first or person-centered language, so we can have that gentle reminder of how we're showing up for care and how we can continue to make sure that we are looking at individuals as a human, as part of us as well.
All right, thank you so much, Elizabeth and Dion and Essence. I am gonna talk just a little bit about the Justice Core services that we have available, and then I would love to start taking some questions from you all. You can use the Q&A function in Zoom. You can also put questions into the chat if that is more appealing to you. Your questions can be submitted anonymously, and I believe that only our panelists will see your question. So there are no silly questions, and even if you think your question is silly, despite my reassurance, no one will see it, and so no one will know that it is your question, whether you think it is silly or not. So feel free to start putting questions in that Q&A function. And then I'll also just talk a little bit about Justice Core. So we provide training on evidence-based management of substance use disorders in pregnancy. You are attending the first of those trainings. We have, as I mentioned, each Wednesday for the next 4 weeks, we'll have another 30-minute session. Next week, we'll be talking about screening. The following week, we'll be talking about assessing withdrawal and also assessing substance use disorders when we're thinking about referrals. And then the last week, we'll talk about treatment and really medications for opioid use disorder, as well as making referrals for behavioral health services. And so we would love to see all of you at the remainder of those trainings. Please also tell your friends, tell your colleagues. We're happy to have folks join, whether they attended the first session or not. And if you are interested in trainings specifically for your facility, we would be happy to help coordinate that. There will be recordings of these trainings that are available. And so you can absolutely, if you wish to share this with a broader audience in your facility, those recordings will be available to you, or we would be happy to help coordinate a training specific to you. We also offer technical assistance, which is really guidance and connections to help jails connect pregnant people and postpartum people with substance use disorders who are showing up in their jails to evidence-based treatment, as well as alternatives to incarceration. So we've heard from a lot of folks that they don't want pregnant people with substance use disorders in their jail because it is a liability and it is stressful. We can absolutely help, both in terms of helping with resources to provide good care for those folks, but also with identifying alternatives to incarceration and helping get folks out of your jails, which I think is probably a win-win-win in terms of the jail staff, the clients that we're seeing, and also our service. That leads to the direct service. So we work directly with pregnant and postpartum clients with substance use disorders, as well as with jails, county staff to identify and implement those alternatives to incarceration. So if you have a client in your jail who you think would be better off in a residential treatment program, please don't hesitate to reach out to us, and we can help make those connections and provide those resources. So I'll come back to this in just a moment so that it is up here. But I just want to acknowledge the entire Justice Core team, and then also our funding from the Doris Duke Foundation. And then I will come back here and just leave our phone number and email address up while we take questions. We have set it up so that I don't think that you will be able to unmute yourselves, but rather can put questions in the chat or the Q&A. And so while we're waiting for those questions to pop up, I have a question for Dion, and I'll kind of go ahead and get us started, which is that, Dion, you talked about, your job is making sure that people get good care. Can you talk a little bit about how you balance, the jail's goal of keeping everybody safe and, complying with sort of the law enforcement role, and also then where the healthcare piece kind of falls into that?
Yeah, so I work for the jail. I work for those guys. So if I need something, and most of the time they're not sure because they're not used to dealing with pregnant patients, right? So I go to the sergeant, and if I need something and it's within their protocol, they will help me out with that. I try to make sure, the ladies, pregnant ladies, get an extra mat, right? I try to make sure I sign out the paperwork for her to get extra portions. So at least I know her back don't hurt while she's in there, and she's not hungry, right? She's getting enough nutrition. And if something else is needed, I work with the group of people, and they help out.
Fantastic. We have a question that I think would probably be best answered by Essence, which is, can you describe what happens after someone refers a client?
Yes, that's a really good question. So the first thing that we do is we complete an assessment. So we gather a ton of information. It's like a interview process where we get some background information about all of the aspects of that person's life. And based off of that information, gives us the information that we need to make an appropriate referral. So when we're thinking about substance use disorder treatment, there's so many ways to treat substance use, right? We have the medication for opioid use disorders, we have the behavioral health, but then we also have the different levels of care. And so the first thing that we want to do is ensure that we are getting people connected not only to substance use disorder treatment, but to the appropriate place in which they can thrive. So once we complete an assessment, we then send out a referral to those appropriate programs. And then we assist them with getting into that program or to those programs. What I mean by assisting, transportation, helping get connected to medication once they leave the jail or prison to maintain that access. And then just check in with them periodically just to make sure that they are still connected. So in short, or in summary, is we did the screening, assessment, refer, and then actually help them get to that location and reduce the barriers that could get in the way, that could make that transition a smooth transition.
Thank you, Essence. Our next question is whether this is just for pregnant people or whether anyone who is dependent on substances can benefit. And I would say that, so at Horizons, we are really focused on pregnant and parenting people and women. And so in terms of referring to Justice Core, in terms of direct service, anyone who is pregnant or postpartum or is parenting, which to be honest is probably going to be most of the women or female people in your facility, is certainly eligible to be referred. I think if you are running into lots of issues with men who are dependent on substances, we may not be the perfect referral, but certainly you can reach out to our team and we can help connect you with other groups that are helping to make those transitions, as well as with your I think your local managed care organization may also be the connection in your county for getting folks connected to residential treatment programs, and that would be a reasonable option. Did I get that right, Essence? I feel like I've learned so much from you in terms of how that all works.
That's correct.
Awesome. So we are right at 12:45, and so we don't necessarily need to keep folks any longer. Feel free to use the rest of your lunch hour to use the bathroom, eat your lunch. And certainly if there are any other questions, feel free to pop those in the Q&A. We'll hang around for a couple of minutes. But otherwise, I hope that we will see all of you next week, same time, same place.